Yeah, hi, good evening all. Am I audible?
Yes, sir.
Okay. Is my slide visible?
Yes, sir.
Okay. So, like basically we'll be practicing a few clinical scenarios, which will be like maybe a video, a communication, and a clinical station today. Okay. So without wasting time, like those who have joined at time, they should have some benefit. So we'll be starting it. So for the clinical scenario, I'll have one clinical examination case which normally you know that when you are sitting outside for 4 minutes, then you do not know what is lying inside. So once you go inside, you get the command of, okay, you have to do the CVS examination, a CNS examination, abdo examination, or the other station. So when you are sitting outside, you are not aware of what is lying inside, basically, which station you are going to get in those cases. So you are completely like going unbiased there. And in the case of clinical examinations, in clinicals, you have two cases which are like fixed. You are sure to get a clinical CVS case, a CNS case, and most likely an abdo case. So these three cases are almost more or less fixed. In the other stations, you can have anything varying from respiratory, dermatology, it can be a thyroid examination, it can be a general physical examination, anything, or a MSK examination in the others. But CVS and CNS is a must for everyone who is attempting a MRCPCH clinical examination. And in the clinical examination station, this is the way you are marked. You have total of eight station, like 8 marks, which you can get in this case. And there is only, and your clinical station is for 6 plus 3, 6 minutes. You will be doing the clinical examinations, and 3 minutes you will be answering the Viva questions to the examiner, basically. So in the initial 6 minutes, when you are interacting with the child and doing the physical examination of the child, you have just 2 marks, maximum 2 marks you can obtain in these initial 6 minutes. But in the last 3 minutes, in which you will be answering the questions of the examiner, the questions are also
Yeah.
fixed. He will be asking you to summarize the things. He'll be asking you to put differentials or the diagnosis. He will be asking you the investigations, the management plan, and if time is there, then he can go further. Normally, in those 3 minutes, the time is very constant. So it is advisable in the last 3 minutes, you have 6 minutes, 6 marks to score. So it's always advisable that you rush up in the last 3 minutes. By rush up, I mean your answer should be to the point and you should not beat around the bush. Because if you are beating around the bush, you'll be wasting your time and the examiner might not be able to ask you a question in the designated time. If he cannot ask you a question which is supposed to be asked in those 3 minutes, he can never mark you. So your that question is lost. So you will underscore in that station, which is like lethal due to the time one. So you should be very much careful for the time stations and you should be aware of how you are marked. Okay. Any doubts in this? All of you are clear in this, right? Marking scheme. Right. So without teaching any of the theories, I'll be moving on to the case discussions, what we'll be doing. So who wants to present the first case? Try for the first case. Someone wants to try a first clinical examination case? No one? Anyone wants to attempt a case? You just want to be passive listeners, all of you. It's not going to help much. No one wants to attempt a case, then I'll choose, pick up a name from you amongst you. Any one of you who wants to attempt? Dr. Pradeep Kumar, do you want to attempt?
Sir, good evening, sir. Actually, I'm the
Hey.
OPD, sir. Sorry, sir.
Acha, okay, not an issue. Dr. Anushya, Are you there?
Ma'am.
Yeah. You want to attempt a clinical case?
Yes, sir. I'll try, sir.
Good. Okay. So I'll give you a scenario. So that
Yes,
four
sir.
minute thing in which you are giving going like waiting outside, na?
Yes, sir.
I won't be giving you that time. So basically, you will be entering in the station into the station when your bell goes,
Yes, sir.
and I will be giving you instruction as an examiner. You will be examining for 6 minutes. I'll give you a ring at the
Yes,
end of
sir.
6 minutes, and the next 3 minutes will be like that. Okay, good.
Yes, sir.
Okay, if you're ready, then I can give you a case.
Yes, sir. I'm ready, sir.
Just a second, I'll put the timer. Okay. Okay, your time has started. You have entered into the station and you have to
Yes,
do
sir.
the previous examination of this 12-year-old boy, Sam.
Yes, sir. Okay. So I enter the room. I wish the examiner. Now I wash my hands. I'll introduce myself to the mm, to Sam. Hi, Sam. How are you doing?
Hello, doctor. I'm fine. Thank you.
Okay. So today I'll be examining you. I'll be very gentle. If you find any difficulty or if you have any pain, please feel free to tell me. I'll just stop the examination. Is that okay? Shall we proceed?
Sure, doctor. Thank you. Yeah,
Okay.
we can proceed.
Okay. Okay, sir. Is there any dysmorphism in Sam?
No, he doesn't look this perfect. He looks like this.
Okay, sir. Okay. So he looks cyanosed. He has clubbing. Uh, both central cyanosis and peripheral cyanosis is present. His eyes are congested. Mm, no obvious dysmorphism. Okay, sir. So are there any devices attached to Sam?
No devices attached.
Okay, sir. How is his dimensions?
He looks thin and height looks okay, not short. Average
Okay.
build.
Okay, sir. Is he in respiratory distress?
No, he's not in respiratory distress.
Okay, sir. So I'll start my general examination from the nail. There is clubbing and cyanosis is obvious. Is there any palmar erythema or any signs of infective endocarditis, sir?
No palmar erythema, vascular nodes, or Janeway lesions. No signs of
Okay.
eye.
Okay, sir. So now I palpate for pulse. How is the pulse?
His pulse rate is like normal volume around 90 per minute, the examiner tells you.
Okay, sir. And now, any IV line marks or any devices in his arm and forearm?
No, no.
Now I'm looking at the axilla. Is there any signs of puberty?
Yeah, he has thin pubic hair present.
Okay, sir. Okay. Now I'm going to the neck. Are there any? There are no obvious dilated veins. No webbing in the neck. Now, no obvious JVP elevation. Okay, sir. Eyes. There is little congestion and yes, sir. Is there any icterus?
No icterus.
Okay, sir. Mouth. Okay. How is the palate, sir? Is it high arched or
Palate looks
no?
normal, not high arched.
Okay, sir. Dental hygiene.
It's okay, looks reasonably well.
Okay, sir. Okay. Any edema, pedal edema or swelling of legs or hands, sir?
No obvious swelling of the hands. And you move down to the legs, it's also not there. Okay.
Okay, sir. So now I'll have with Sam's permission. Can I examine you? Can you please help me by undressing yourself?
Okay, sure, doctor. So he
Yes, thank
removes
you.
his shirt.
Yes, sir. Thank you, Sam. So inspection, I'm able to see a midline scar and also a right thoracotomy scar and a few ICD marks, I guess. ICD scars.
Okay.
Yes, sir. There are no obvious dilated veins over the chest. Nipples are placed normally. Okay. Now I'm moving on to the palpation. How is the apex beat, sir? Where is the apex beat?
How are you checking for it?
Yes, sir. I'm checking for the apex beat by both my hands. Is it
It's in it's in the left side, just 1 centimeter medial to the mid clavicular line
okay, sir.
in the fifth
Uh,
intercostal space, RV type.
okay, sir. Okay. Now, okay. Apex big. There any parasternal heave or any thrill palpable, sir?
No parasternal heave or thrill.
How's P2?
P2 looks to be single, non-loud.
Okay, sir. Okay. Now I'm moving on to auscultation. How is the heart sound, sir?
Okay, you have auscultated in all the four heart areas regions, right? So first heart
Yes,
sound
sir.
is normal. Second heart sound is looks to be appears to be single of normal
Okay, sir.
intensity. No third heart sound, no fourth heart sound.
Okay, sir. Okay. So, are there any murmurs present in any of the
Not in
areas?
these four areas, no murmur. No,
Okay.
none of these areas. Four areas, no murmur.
Okay, sir. Okay. So now I like to look at the back. How is his back? It's normal spine, everything.
The spine looks normal, no scoliosis or kyphosis.
Okay, so abdominal examination. Are there any hepatomegaly?
No hepatomegaly.
Okay, sir. So, so in order to finish my examination, I will I will take blood pressure, JVP. I will check for the JVP elevation. I'll take saturation, and I'll look for a Tanner staging, and I'll finish my examination, sir. Shall I summarize?
Okay. No, you still have some more time, doctor. If you want, you can examine.
Okay, sir. I'll check for the respiratory system. Is it normal? How is the air entry, and are there any additional added sounds?
No adventitious sounds. Air entry looks to be equal bilaterally.
Okay, sir. Um, mm, I think I finished.
If you have finished, you can ask Sam to like put on his shirt back.
Yes, sir. Yes. So thank you so much, Sam. Thank you for the cooperation. Now I'll help him, and I'll help him to dress himself, and I'll thank the mother, and I'll thank the examiner also.
Okay, 6 minutes are over, doctor. So you can summarize your positive findings, doctor.
Yes, sir. Today I got the opportunity to examine Sam, a 12-year-old boy, Sam. I did the cardiovascular examination in him. So there was no obvious dysmorphism present. However, he was looking thin and average build. However, I would like to plot it in a proper growth chart. There were no devices attached to him, and he was not in respiratory distress. On general physical examination, I was able to appreciate both central and peripheral cyanosis, and he had a pan-digital clubbing in him. And he had signs of puberty, like thin pubic hair. And his eyes looked congested, suggestive of polycythemia.
তাহলে
And
ব্রাশ করে এসে যাও পানি
his
খেয়ে এই
lips
যে
was
পানি
also
দিয়েছি
cyanosed. Then on cardiovascular examination, I found there was a midline scar and a right thoracotomy scar and ICD scars. Apex beat was present in the left intercostal space, 1 centimeter medial to the midclavicular line, and in the fifth intercostal space, and it was RV type. In auscultation, I was able to hear a single second heart sound. There was no obvious murmur. His back was normal, and there was no evidence of any hepatomegaly or pedal edema in him.
Okay.
Yes,
So
sir.
putting all things together, how do you put your like, do you want to put any differential or any diagnosis for these findings?
Yes, sir. It could be a complex congenital heart disease, most
Okay.
probably of single ventricular pathology.
Mhm.
Since multiple scars, surgical scars were all present, I would think there were some palliative surgeries that has been done, and now, based on his presentation, there could be some residual heart disease in him, and he did not have
Okay.
any evidence of infective endocarditis or congestive cardiac failure. Sir.
Okay. What other than chest X-ray, ECG, and echo, what
Yes,
other
sir.
investigations do you want to do in this boy,
Sir,
Sam?
I would like to do a complete blood count and look for the hemoglobin, sir. Since he looked, eyes look congested and polycythemic, I would like to rule out polycythemia, or how much is the hemoglobin, hematocrit, and PCVS. Sir.
Okay. So suppose his hematocrit is like 65 at this stage.
Yes,
What
sir.
do you like to advise him?
Is he symptomatic? Or, yes, sir.
No, he's
He's
not
a
symptomatic. He was there with you. He was not symptomatic.
Yes, sir. Then I can advise a proper hydration, and if needed, phlebotomy can be done. Sir.
Okay, fine. So which all team members would you like to involve in his management overall?
Yes, sir. I would like to involve the multidisciplinary team, including my consultant pediatrician, cardiologist, cardiothoracic surgeon, respiratory physician, nutritionist, dietitian. Um, yes, sir.
Okay, your time is over, doctor. Thank you.
Yes, sir. Thank you, sir.
So nice, Dr. Anusha. How was it? What's your feedback? Positives, and where do you think you need to improve?
Yes, sir. I was very nervous. I should.
It
Yes,
didn't seem to be.
yes, sir.
You sounded confident. That's okay. Okay.
Okay,
And
okay, sir.
anything else? So
Mhm.
I'll tell you the positives first of all.
Okay,
So
okay,
there
sir.
are lots of positives to be enumerated.
Yes, sir.
So you're very structured in your examination, and
Yes,
so it means that you have practiced well. That's a very good thing. This is the only thing which is needed to pass this examination. 95% is only your practice, which she has done, which is obvious to all of you, which is clear. So there is no doubt that she has practiced well and she is going on the right path. So those who have practiced will easily pass this exam. There is no doubt in that. Okay. Only 5% is knowledge, 95% is your practice. That's it. So it was good. You were very structured from the beginning, and the way it has to be gone, you entered into the room, did your wipe, then
yes,
you
sir.
did your four DDDDs, moved on to the hand, move on to the. So these things, like it was obvious in these, but ideally you should be like showing, okay, do it like this for me and all, the way you will
Okay,
do in
sir.
examination just for your practice. Okay. It
Okay,
was
okay,
very
sir.
obvious in this case that cyanosis is there and all those things are okay, but have the habit of asking them to do that, even if it is
Okay, sir.
obvious to you. Okay, then you
Okay,
will
sir.
say, okay,
Okay.
clubbing is there and all those things. Okay.
Okay,
Then
sir.
you moved
Okay, sir.
on to the head and neck. You checked for the pallor. It was good that you didn't say much for the pallor because he was congested. So it was
Yes, sir.
obvious that he should not be pale. It was red. And icterus you checked for the oral hygiene, you checked for the neck, any obvious dilated veins or JVP, which is
Yes,
obvious.
sir.
Ideally, yeah, you should not examine JVP much time, but yeah, if it is dilated, you can comment on it. And you can see in
Okay,
the
sir.
last, you would like to complete your examination by formally doing a JVP examination. Okay, which you
Yes, sir.
did in the
Yes, sir.
last. That's okay.
Yes, sir.
When you moved on to the precordium, it was good for inspection. You inspected him all the 20, like you have to inspect him from all the sides, 360 degrees basically. So you
Okay,
saw
sir.
for the lateral side, you saw for the mid sternotomy scar, you said went on the back. Then you went on to the
Yes, sir.
palpation. Remember, previous palpation is very important. You have to put both your hands in both sides because there can be a case of dextrocardia or a
Dextrocardia.
situs inversus totalis, which
Yes,
can be
sir.
there, which you should never miss, which you did. That's why I asked you to enumerate how are you checking for it. And that is the way you do, which you did. That was correct. So always
Yes,
see
sir.
that. And then the way you do your regular examination, then you will be palpating for all the areas. Then you will be palpating for like any thrill, parasternal pulsations are there. Okay.
Yes,
Depending on
sir.
your finding, that if you are getting thrill anywhere, you will like to see how much is it conducted and all those things. Then you move on to normally auscultation. Auscultation is done in the all four standard areas, followed by other areas which you can suspect. In this case, it can be like there is a lateral thoracotomy scar. So there can be a peripheral shunt, right?
Yes, sir.
There
Yes,
can
sir.
be a peripheral shunt like BT shunt and all. So it should be auscultated laterally also, not the
Okay, sir.
four routine areas. You have to auscultate on the back also routinely in all CVS cases because they can have collaterals.
Okay,
So
sir.
don't forget to auscultate the back and the peripheries. Peripheries for any BT shunt or even PDA murmur. It won't be heard in the regular four areas which you do auscultation, the valvular. Okay. So that is
Okay,
to
sir.
be done. Then it is obvious when you are examining, normally when you are verbalizing, you normally take more time, but when you are examining, it will be faster. But it was
Okay,
good
sir.
that you finished your things in 5 minutes and 15 seconds only. That was
Okay,
good.
sir.
But once you have finished, don't like normally the examiner will tell you, okay, this is this, but you should have in mind, okay, after I have finished what I can do, you have to tell in order to complete your examination, you will do this is which you did, and then you thank him.
Yes,
Don't
sir.
do like if the examiner is telling you have more time, then I'll go again, jump to something. Don't do
Okay,
that.
sir.
That is not
Okay, sir.
preferable. Okay. If you think
Okay,
that
sir.
you have finished, you have finished. It should be like you should be that confident. Okay. If he's giving me time, it's my time only. It's not the examiner is giving you extra time. He just
Okay,
is
sir.
telling because you have time. He can't ask you questions. He won't ask you questions before your 6 minutes because he's the last 3 minutes are to ask questions. He will not talk to you in those 6 minutes. Correct.
Okay, okay,
And
sir.
if sometimes if the examiner doesn't want you to examine particular things, he will tell you clearly. Like if you ask him, like you maybe I like to check his BP and all, he will say no need. So that's okay. Okay, and he will clearly say those things. Okay, no need and all. So that
Okay,
way.
sir.
So it was good actually. I found your attempt to be good and you were very to the point the way it should be gone. Like he had multiple scars, a midline sternotomy scar and a lateral thoracotomy scar. So something complex is lying there and still he is so much cyanosed. So you can
Yes,
see
sir.
it's not a corrective, something has been done. It should be something which is like has some palliative procedure has been done. So most likely complex, now you can put a single ventricle physiology. What was the other thing which was hinting that it is a single ventricle physiology other than multiple scars? Dr. Anushya?
S2, single S2, sir.
Ah, very good. Why is there single S2, by the way? How do you
Uh,
explain that?
um,
Why should there be a single S2? What do you think this S2, this single S2 is due to? Which component of S2?
A2, sir.
A2 or P2? A2. Okay, why not P2? Why are you not hearing P2? What do you think?
Because of the pulmonary hypertension and
What
decreased pulmonary blood flow.
You know,
Hypertension
in the
apart.
case of if there is pulmonary hypertension, P2 is loud. If the distal pressure is high, P2 will be loud. Remember this funda.
Yes, sir.
There are
Yes, sir.
two things which you have to understand for all of you. Okay. If the
Yes.
distal pressure is high, the closing valve will be loud. So if there is
Yes, sir.
PAH, the P2 will
Yes.
be loud. Come to the
Okay, sir.
other side. If the P2 is soft, it means there can be multiple things. P2
Okay,
is
sir.
soft or P2 is absent. Think that P2 is absent. If P2 is absent, it means the second valve is atretic. That you understand. Okay, it can be
Yes,
a
sir.
case of pulmonary atresia or
Atresia.
correct. Second thing,
Yes, sir.
only one valve is there. It's not
Yes, sir.
atretic only like truncus. Then P2 will be absent. Only one you will hear. Matlab, only 1 second how you can hear. Or it can be sometimes they are antero-posteriorly located.
Okay,
The
sir.
great arteries normally how are they located? You know, PA is anterior and towards the left, aorta is posterior and towards the right. Okay, they are
Okay,
not
sir.
antero-posterior. बिल्कुल सामने सामने नहीं होते. They are like this, not like this. If they are antero-posterior, which happens in the case of TGAs and all. In TGAs, the great arteries are antero-posterior. So you do not hear the second component because it is very far from your auscultation. So you don't hear. So these are some of the causes in which you hear a single P2. So in this case, single P2 was there, and you are thinking single ventricle physiology. What do they do in single ventricle physiology? There is a surgery which is known as Glenn surgery. In the case of Glenn surgery, they connect the SVC to RPA, right pulmonary artery, and they will disconnect the normally. In most of the cases, they will disconnect the RV to PA communication. So if they are disconnecting the RV to PA communication, the P2 component is gone, right? You cannot hear the P2. That is why you are not hearing the P2. You are just hearing the A2. Okay. That's the reason.
Okay,
So
sir.
good. Basically, you don't have to dive so much inside unless and until some cardiologist is taking inside in your exam and he will ask you these things. But what you should know is you have to utter a complex cyanotic congenital heart disease. Most likely looks to be a palliative surgery because he is still so much cyanosis. By seeing him, it looks that he should be around 60 to 70 max, that to not even 70. Second thing, if ever you are asked for investigations, you all of you will say X-ray, ECG, echo. That's good. But the most important thing, which was clinically obvious in this case, is you should see for his PCV. That is very important because his hematocrit tends to be high and he might be having like polycythemia, which is obvious very. So you might have to do a phlebotomy. There is no clear-cut cutoff for phlebotomy, but if the child is having symptoms and it is above 65, you can go ahead with partial exchange or phlebotomy in these cases. Okay.
Yes, sir.
So it was very structured and I really like it was a good attempt. Very good. Nice
Thank
attempt.
you, sir. Thank you, sir.
Good. I'll move on to the second, one more case. I'll give you those who want to practice for video station. I have one more video I'll give. So for video, I'll just tell you the timing. All of you know that when you are sitting outside the video station, you have a command. You are sitting outside the video station for 4 minutes normally, and you will be given a command. In command, it's not much history written. Just 1 or 2 lines will be written. Does the video have a audio or not? If the video has a audio, then you will be having a headphone. So you are supposed to use that. It will be clearly instructed outside only. So outside instruction is to be read. And once you enter, you have 3 minutes to run the video. The laptop will be in front of you. You will be running the video again and again. And if the audio is there, put your headphones and hear the sound. Normally in respiratory conditions and all, when they want you to hear those things, those respiratory sounds, they will give you the audio. So audio is to be heard, and for 3 minutes, all 3 minutes is yours. After the 3 minutes are over, the examiner will start asking you the questions. In this case, also the questions are very structured. You'll be asked the structured questions only, not here and there. So you'll be asked to describe your findings. You will be asked for the possible differentials. We will be asked for the history points which you want to take for those differentials. How do you like to examine that patient? What investigations do you want to do in that child? And what will be your treatment and management approach? After this, normally there are 6 minutes in the case of video. You might be having some time. So examiner might ask you some additional questions, but these are the must questions which he will ask you in a structured fashion. Okay, that way. And how are you marked in the video station? This is another thing. You have total of 6 marks in the video station, and I have seen more than 90% of the students are able to score 6 out of 6 in both the video stations. It's one of the stations which is like very everyone knows what is going to come, because RCPCH has a proper set of videos which are there, a library of videos which are there. So they know those are to be repeated. They are around like 60 to 70. That only is repeated again and again. So, and these videos questions are also very structured. Once you have identified, you'll be using them. So it's one of the stations which no one of you should get like attempt even to lose a single marks. So you have 2 marks for identification of the clinical signs, 2 marks the way you interpret those signs, the clinical reasoning, and 2 marks for the management planning. Okay. So who wants to practice one video station? Any one of you? Someone has put a message. I'll just see. P2. Okay, Dr. Rubaisha. Good. Correct. So someone wants to present a video, like practice a video station. No volunteers? No one wants to present? Then I'll have to catch by names. Message was put by Dr. Rubaisha. Dr. Rubaisha, Abdullah, you want to present a video station?
Yes, sir, I can try.
Good. Okay. So, like, I'll give you the 4 minutes instruction outside only, that
Okay.
there is no audio in this video. Okay. And you will have three
Okay.
minutes to see the video, and then you will have a timer ringing. And after that 3 minutes, you'll be asked to answer the questions. Okay. If you're ready, I can
Okay, sir.
start the timer for this. So this video doesn't have an audio. Okay. I'm
Okay.
starting your timer, and this is your video. You can see it for whole 3 minutes. I have put the timer. I'll let you know. You don't need to read those parts which are written on the down, the hints and all. So you can see the video, whatever is being seen, and the rhythm and the patient and all, and what is being given, and then you can describe it.
Yes, sir.
You have 30 more seconds, doctor. Just utilize that part, then you
Okay.
start. Not an issue. I'll tell you. Okay, doctor, you can describe your findings, which you saw in the video.
Sir, I can see computer. I can see a monitor which is showing a heart rate of 200 and saturation of 100 and the respiratory rate of 44 and showing there was the it was showing the and there were two there was uh, uh, ECG was being taken and heart rate is showing only the there is no P wave and there are two cannulas are attached to the children to the child and it was the picture was not clear and adenosine was being given and the person was giving the medical professional was giving the adenosine along with the he was clearing the fluid with he was clearing the line with the normal saline as well simultaneously and it was showing that the nurse was taking the ECG and the heart rate is being reduced after being given adenosine and it was reduced to uh, like 90 I think.
Okay, good. So, what do you think is the diagnosis? What was the condition the child was having?
Yeah, so most likely it was SVT and yeah, ventricular tachycardia, sinus ventricular tachycardia.
Mhm. How do you say that it is SVT by the ECG? What are the
Yeah,
points which made you say?
the heart rate usually in children it was 180 or greater than 180, or in infants it's 220. There was no P wave prominent, and there is narrow QRS complexes.
Okay, good. So, what points in history would you like to ask in this case?
Like, sir, I would like to ask onset, course, and duration for which the child is being having this complaint, and will ask for any fever, dehydration, and any prior heart issues, and yeah, dehydration as well for this, and that's it. Any
Any family history?
cyanosis, any family history of congenital heart defects.
Okay, okay. So, how do you like to the child's heart rate has returned to normal now? Now
Yes,
you
sir.
are there in ER. How would you like to examine this child now at this point?
Yeah, I will like go for meanwhile checking the vitals. I will examine the patient for heart rate, BP, and everything vitals, and then we'll check the precordium. First of all, I will do the inspection and we'll see and is there any scar, like the and we'll go for palpation for any thrill or any added sound, any thrill and heave and any dextrocardia, and auscultate for WPW or yeah, auscultate for any added sound other than the heart sounds. Yes, sir. And for look for any JVP, raised JVP, and other the chest examination as well, other than cardiac.
Okay. So at this stage, his heart rate has returned to normal. What all investigations would you like to order at this point?
Yes, sir. I would like to do the ECG and at the normal ECG at the time when the child is stable, and the chest X-ray, ECG and echo to the main two investigations I would like to do.
What you would like to see in echo?
Yes, sir. I would like to see any like I think the WPW sir, syndrome. Yeah,
So for the
I would like that to see delta waves in ECG if I am suspecting this.
in ECG, in echo, what do you want to see?
Um, in echo, I would like to see, sir. I don't know, sir.
Okay, that's okay. Any other investigations other than ECG and echo? Would you like to check his electrolytes?
Yes, sir. For dehydration, or I would like to do CB, complete blood count, and serum and electrolytes, serum electrolytes.
Okay. Would you like to see his hemoglobin?
Yes, sir. CBC, complete blood count to see his HB, because
Mhm.
anemia, like maybe the cause of yeah, to increase.
Okay, good. So
Yes.
suppose you are there to manage this child and you know that this is a case of WPW syndrome based on
Yes.
like your cardiologist's opinion. So
Mm-hmm.
how would you like manage him now? What are the
Sir,
advice would you like to give him?
yeah. If it is the first time, we can just refer to the cardiologist, or if it's the first time, we cannot give any treatment medicine for this. But if it is recurrent, or we need like to give the beta blocker to control this SVT, and the correction by the cardiologist.
Mhm.
Total correction.
Okay. Suppose that you did a echo in this case as you wanted to do, and there was severe LV dysfunction. Would you still like to give
Mhm.
the beta blocker in that case?
No, sir. Beta blocker will reduce the heart rate.
Okay, time is over. Okay, fine.
Thank you, sir.
Okay. So,
Sir, I was not prepared at all.
no, 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 don't worry. It was good actually. Your attempt was good, and the way you described the video was absolutely perfect. You tried to take your like full time and you described the positive findings which were like obvious. And those things which are not clear should not be commented. And you said it clearly that okay, I'm not a like you are not sure of the child, the age of the child, and all those are clear. That's good. I'll just before I forget, I'll tell you whatever investigations you are uttering, you should have the reason why are you getting that. Otherwise, don't utter. Because if you're getting an investigation done and you don't know why are you getting it done, then you will be caught easily. Right. So you said ECG, you had an answer you wanted to see for the delta wave or WPW. That is acceptable. And you want to see the other things if it is obvious in ECG. That is the perfect answer. Why do you want to get an echo in this case? Any one of you? You all can interact.
To
Why?
assess the structural anatomy and cardiac function.
Correct. Very good. So echo you got, you said in your history, what did you ask? Any previous history of heart disease? So you are expecting that there might be some congenital heart disease also. You wanted to ask that point in history. So you should confirm it with the echo, right? So you want to rule out the structural anomaly. And second thing, you want to see the function. This tachycardia might be a reflection of some maybe cardiomyopathy due to which, or maybe myocarditis, we don't know, due to which he has tachycardia, right? Do you accept that?
Yes, sir. Yes.
Or this tachycardia might had led to cardiac dysfunction. Both ways can happen. So
Yes.
always on have if you are having any tachycardia induced cardiomyopathy, be it sinus tachycardia or SVT or a VT, I'm not concerned. Whenever you are having a tachycardia myopathy, like a tachycardia tachyarrhythmia is there, always see the echo for the structure that is good, then for the function. And for the function, when you are seeing, it can be anyway. This tachycardia might have led to dysfunction, or the cardiac dysfunction, which can be due to DCM or myocarditis, that is leading to tachycardia. That is why you see for the dysfunction. Very good. And whenever you are
Okay.
seeing these cases, always rule out electrolytes. Think for the common causes first. So the common causes, it can be maybe it can be anemia. You should always say, okay. It can be electrolyte
Mm-hmm.
imbalance. You want to see for the thyroid function test. It can be hyperthyroid, right?
Yes, sir.
Will
Yes.
lead.
Yes.
So these are the first thing when the child with tachycardia comes to our OPD, they come daily, at least 3 or 4 cases I see daily. So these are the common things we rule out first. Okay. So
Okay.
you will rule out anemia, you will see for electrolyte imbalances, you will see for thyroid function. Then you will move on to the ECGs and the echoes, right? So those things are to be said. As a pediatrician, we have to rule out these from our side. Then the cardiologist will jump in and he will do the echo and all those things, right? So those things should be done from your side. It was good. So that was the
Okay,
answer
sir.
of your question for that. And one more thing, it was good that when there was dysfunction, severe dysfunction, at that time, you did not add the beta blocker because tachycardia, and why didn't you add beta blocker? I want to understand your explanation. You are right. You didn't want to add beta blocker when there was like tachycardia due to that. You saw that the dysfunction was there and you didn't wanted to add beta blockers. Why?
Sir, beta blocker will further compromise, will
So if it is
heart
a,
rate will
yeah,
be low because of it.
correct. So if it's a case of acute decompensated heart failure, we don't know what the diagnosis is, right? If it's a case of acute decompensated heart failure and tachycardia is there, it's basically to maintain the cardiac output because the stroke volume
Yes.
has decreased. The heart is pumping less, hardly anything. So the stroke volume, the amount of blood which is being pumped by the heart in each heartbeat decreases. So to maintain the same cardiac output, the heart wants to increase the heart rate. So stroke volume into
Yes.
heart rate is it's your cardiac output. So that is why tachycardia is there. So you should never, in the case of acute decompensated heart failure, you should never give beta blocker as first line. Otherwise, the child will become sicker and his decompensation will increase. Because if you decrease the heart rate, his cardiac output will suddenly decrease. So never
Yes.
give beta blocker. That was a correct answer.
That is because
Correct.
of like low BP, the heart rate is increasing for the compensation. So we should not decrease the heart rate.
Correct. Yeah. To maintain that
Once,
cardiac output,
yeah,
to perfuse all the
once the
organs.
child is stable, we can give the beta blocker.
Of course, we have to give that. Once the child has been decompensated, you have given him like inodilators like milrinone and all. You have decongested him with Lasix and all. He's a bit stable now. Okay, right. You do not find that there is any hepatomegaly, no LVS3 and all. So he is like coming out of oxygen and all those things. Then you keep on adding the AC inhibitors or ARBs which you give. Then you add beta blockers before discharge. So this is the way in which stepwise management of heart failure is done. It's not done in one go. You push everything in day one. He will decompensate. Okay. So you have to
Okay.
decongest, decrease the preload. Basically, decrease the preload first, increase the contraction of the heart with inodilators and all, milrinone and all. Then you decrease the afterload with the AC inhibitors. And then you do the
Okay.
rate control after you have done the three parts. Okay, good.
Okay, sir.
Very good. It was a good attempt again, Dr. Ubaisha. Any
Thank you,
doubt
sir.
anyone has? Anyone wants to ask any question? No question, then I'll give you another video. I have one more video. Any one of you who wants to practice one more video, which will be the last for today? Any volunteers? Any volunteers for video? Dr. Jaya Gopal, you're there. Dr. Kostu,
Sir, sorry, sir, I'm on the emergency, sir. You can't.
okay,
Okay.
not an issue, not an issue. Anyone else? Samsung SM G781B, not interested. Dr. Saira Tasawar, no one. Dr. Samira, no one
If
wants
anyone
to
is
do?
interested, I can try, sir.
Yeah, if no one will,
Uh,
that's better.
Sir,
Someone else?
I can try, sir. I don't know, but
Dr. Abdullah. That's
Okay,
okay.
sir.
That's okay. Okay, okay. Okay, Dr. Anusha, I'll give him.
Yes,
Sorry.
yes, sir, yes, sir, sure.
Okay, Dr. Abdullah. So you have a video station. The way it has been done just now, it will be the same structure. You will have 3 minutes to see the video, and the last 6 minutes will be for your discussion with the examiner. Okay?
okay, sir.
Okay, not an issue. Dr. Samira on duty. Okay, that's okay. Not an issue. So I'll just a second. Are you ready, Dr. Abdullah?
Yes, sir. I'm ready.
Okay, okay, good. So this video again doesn't have any audio in it. Okay. So your
Okay.
time has started and this is your video. I'm running it for you. You can see it for 3 minutes. I'll tell you when the 3 minutes are over.
Okay, sir.
Okay, doctor, you can describe your findings.
Okay. I can see two young boys, probably in a hospital setting. On examination, they were conscious, playful, having no dysmorphic features, and the doctor was performing different maneuvers on them. They were able to flex and extend their thumb and can hyperextend their thumb in different positions. They were also able to get their toes and legs up to their head region, which shows extensible joints in them, sir.
Okay, good. So would you like to put some like differentials for the above findings which you have got?
Um, I think these are like connective tissue disorders,
Mm-hmm.
like Ehlers-Danlos syndrome.
Okay. Okay, good. So what
And
points in history would you like to ask in these child?
I will start from onset, duration, any progression, and any aggravating or relieving factors. And I will specifically ask for genetic history and family history. Are there any other siblings have also these? And specifically antenatal history, natal and postnatal history, and developmental history is also important, that they have achieved milestone on time or not, and any past history, any history of falling or injuries to them, and how they behave in school and perform their day-to-day activities, how are they coping with it and their family. And
Okay.
if they are in any medication, then I would also explore the medication or any therapy to ask about that.
Okay, nice. So how would you like to examine these kids?
I would like to do full Pigalis examination
Mm-hmm.
to perform a different maneuvers on them and to check each and every joint in which we have to follow a different steps. And
Mm-hmm.
I would also to do the CNS examination and look for any dysmorphic features
Okay.
in them.
What do you expect in the case of CNS in these kids?
Mm, is um,
Okay, that's
the
okay.
joints. Yeah, okay, sir.
Okay. Any other system would you like to examine? Any other things?
Yes, respiratory examination, sir.
Good.
Respiratory and
Okay.
cardiac examination.
Okay. Would you like to examine his eyes in those connective tissues disorders?
Yes, these are also important for ectopia lentis
Good. Okay.
and to rule out Marfan and cystinosis.
Okay. Fine. So, how would you like to investigate these kids?
Mm,
Like, suppose it's a case of, I tell you, Ehlers-Danlos loss. Okay. How would you like to investigate in this case?
I think, sir, genetic testing for them
Okay.
and
Right.
mm,
Okay.
and ophthalmo fundoscopy
Okay.
examination, sir. Echo is also important.
Fine. Suppose it's a case of like Marfan syndrome. Okay. How do you like to investigate this now? Do you have some criteria to make a diagnosis for Marfan's? Are you aware of something like this? What are the points
Marfan.
for like diagnosis?
Sir, basically, actually, Marfan is a clinical diagnosis. We
Okay.
usually diagnose, but we do the echocardiogram to
Correct.
rule out
Okay.
cardiac disorders and
Mm-hmm.
um,
Okay. So which all team
yes,
members would you like to
hormonal.
involve in this the management of this child?
Sir, I will go through a multidisciplinary approach in which I myself and a pediatric rheumatologist, physiotherapist, nutritional support, and psychosocial support will be involved, sir.
Okay.
And then according to the specific condition, sorry, sir.
Okay.
This is my first
That's
time
okay.
and I am not prepared, sir.
That's okay. That's okay. So what advice would you like to give to this child? Only two is advice.
Uh,
Okay. Your time is over, doctor. That's okay.
okay, sir.
Okay. So how was it, Dr. Abdullah? You were saying you are doing for the first time, but you look to be like
Yes.
very structured and like your performance was really good. It didn't look like the first time, but it was very good.
Sir,
Performed very well, actually.
I have started preparing, but
Good. No, yeah.
haven't practiced with anyone, sir. This is my first time to
Acha,
practice
that's
with.
very good. I must say that you are absolutely on the right track. The way you are doing is absolutely on the right track. Okay, this is the way it should go, or you have caught it very like fast. That's a very good thing. So, what I advise for you all is you all need to practice with partners. Maximum the group should be of three, not more than three. Otherwise, you won't get much time to practice. And when you have got dates of examination, change your partners to those who have exams with you rather than one has got in waiting list and one has got a confirmed seat because or one hasn't got a seat. So the level of seriousness will be different for all the three categories. So once you get the dates, you should have a partner who also has the exam on more or less the same time. First point. Second point, the group size will reduce from 3 to 2 in that time, because getting all the three people at one time might be difficult, and you should not waste your time, and you have to practice more once you get your dates. So daily you have to practice all the stations once you have got your dates of the examination. So it is only possible to daily practice all the stations when the number of partners are less, because this is a thing of not knowledge. This exam, no one is testing your knowledge. They have already tested all your knowledge in the previous three theory papers. They want to see you how safe a doctor you are and your way of approach to the patient. Okay, your knowledge matters only 5%, which you all have reasonably well. Okay, they see your approach and all. Even if you don't know a thing, your approach, you can describe your findings in the video which you saw. Then you can make your differential based on your findings which you saw. And based on those differentials, your history will be based on taking out those points, right? Then you will examine the way you have to examine the system. That is standard for everyone. For investigations, they will be giving you, suppose this is your diagnosis, how will you investigate? In video station, the examiner has the, like examiners are instructed that you have to give the diagnosis. Then they will ask you for the investigation, because maybe your differentials you have put the main diagnosis as one of the last diagnosis, or maybe you have not put it. So you should not underscore in that particular part of investigation. So they will give you, suppose it's a case of Ehlers-Danlos. So how will you proceed? Or suppose it's a case of Marfan's, how will you proceed to investigate and manage? So they will be going by that way. Okay, that's the way. So I must say it was like a very good attempt, all of you three. And in this case, what was important, I was asking for Marfan's. There is something known as Gnath criteria in that. Okay, GNETH, that's somology. So in that case, there are like the points for diagnosis. There are like, you have genetic test of fibrillin, one gene mutation. You have aortic root dilatation, in which leads to AR. You have ectopia lentis, and you have family history. These are the four core points in that. Okay, after that, you have many physical signs and symptoms, which are scored as a point of 2, 1 like this. Then you will add on all these and put a diagnosis, something like this. But the four things are very important: the family history, ectopia lentis, dilatation of the aortic root, which you see in echo, and your this fibrillin gene mutation. So these things you can go through it. It's available in easily anywhere. So that is the way it has to be approached. So it was a really good attempt by all of you three. Any doubts? Anything? Any one of you wants to ask anything related to this case or any case? Any clarification? Anything you need? Nothing?
Yes, sir. You asked the question which two advices you want to give to the
Yeah, what do you want
parents
to give advice? What advice do you want to give to those children?
to play
So they,
safely and to cardiac
correct,
activity should be like limited cardiac
right. So
activity,
first thing is like, if they are,
physical
they should
activity.
not do hyperextension things, exercises and all, even if they are able to do. What is it now? They will be going to the schools. They'll be showing to other kids, and other kids will be encouraging. Okay, he is able to do like this and all. So it should not be encouraged. So they should not be hyperextending their joints, and they should have regular physiotherapy exercises. They have to have regular physiotherapy, and they should not hyperextend their joints even if they are able to do. And those things what you said can be added. Okay, like
Okay, sir.
cardiac
Okay.
examination, if it is a Marfan's, eye examination. So Marfan's needs a annual cardiac examination after 12 years of age. So not annual, 2 yearly cardiac examination if it is normal, because root dilatation is known in that connective tissue disorder. So that has to be done cardiac examination. So those will come in your advice. Okay, that way.
Okay, sir. Okay.
And also to maintain a ideal body weight, sir. There shouldn't be no
Ideal
obesity.
body weight. Correct, correct. You're right. You're right. True. They should not be overweight. So what happens these days now, like many of the things, if you people, all of you must be using AI tools now. I use a lot of AI tools. So you should be using your AI tools even for the preparation of your clinical MRCPCH for getting your things. So you can just write the commands like I use Cloud, that is considered like very good for academic purpose, not the standard chat GTP. So Cloud will have lots of like the way it wants to be done in the MRCPCH clinical fashion. You can give the command. So this is like MRCPCH clinical, give me those sort of answers, or how should I answer? It will give you a structured answer. So that's also good for practice. Okay, you can get those things.
Okay,
Okay.
sir.
Yeah. Okay,
Thank,
if no other
thank you,
doubts
sir.
or anything, then we'll conclude. Okay, thank you. All the best. Keep on practicing. The only mantra to success is to keep on practicing. Okay, all the best, all of you.
Thank you, sir.
Bye bye.
Thank you, sir.
Any
Thank you, sir.
doubts you can always put up in the groups, which are like common groups. Okay, we'll try to solve them out for you all. Okay, all the best.
Thank you.
Thank you, sir. Good night.
Okay, good night.